Madam, who is a distinguished psychiatrist and a consultant in palliative care. And we welcome you, Madam. We enjoyed the last class and we hope to enjoy further.
Thank you so much. Thank you so much for inviting. And if I can just have all your videos on, please. Whoever can put on their videos, please put on your videos. And I think about 2 weeks back, am I right? We discussed about dignity conserving care. Am I right?
Yes,
Yeah.
We discussed on dignity conserving practices.
Practices,
On the
yeah.
last class. Yeah.
Yeah, thanks. So,
Okay, ma'am.
yeah, thank you so much. So 2 weeks ago we did that. So this is an extension about that. And today we will look at what is dignity therapy, what are the steps, and what is the evidence that it works or it doesn't work. Okay, it's based on that. So you remember we spoke about dignity last time, right? What is the definition of dignity in the healthcare we discussed? Especially in terminally ill patients, isn't it? So does any one of you remember what were these concerns? Does anyone remember? Okay, I can see something in the chat. Okay. You can put in the chat or you can even tell me, unmute yourself and tell. Do you remember? Or you want a small revision? Yeah. So you remember this, right? Do you remember seeing this? Yeah. Yeah. So we looked at what were the main concerns of dignity in terminally ill patient, isn't it? Yeah. One was something to do with the illness, that is level of independence and the amount of distress that the symptoms cause. These can affect an individual's dignity. The second one is the psycho-spiritual landscape of that individual, what that individual thinks and practices. Okay, it is about the personality of that individual. And third is the environment, how the environment treats and the concerns about the environment. So these are the three things that can impact an individual's dignity. So among those three things, there are multiple things that sort of contribute. So I will first have a small case discussion. Okay, we have Naina, who is 65-year-old lady. She had metastatic pancreatic cancer. She had Parkinson's disease. She had diabetes, hypertension, and renal failure, CKD 3, stage 3. There was progressive deterioration in her neurological function. She had a lot of tremors. There was rigidity, and she had severe intractable abdominal pain. This abdominal pain was secondary to the pancreatic cancer, and she had cellulitis of one leg, and on the same side where in the lower area she had cellulitis, there was fracture of the femur, and this was causing severe bone pain in that side. The cellulitis was causing a pain, the fracture, and there is the abdominal pain because of the cancer. And the worst aspect was she had severe tremors in all the limbs. So every time the tremor was there, the fracture, that would cause more pain. That limb would sort of shake and that would precipitate the pain for her. She was irritable and crying. She was refused to meet friends. She was extremely fatigued, not eating adequately, and her sleep was disturbed. She knew, she was very educated. She knew her diagnosis and prognosis, and her son was in US. They had only one child who was in US, and she was not, when we started her on anxiolytics and antidepressants for much of her this thing, she was not able to tolerate. She would become excessively drowsy, probably secondary to the CKD that she was having. She was not able to tolerate the pain, benzodiazepines also. So this was this lady, and when we asked her actually about one of the questions that we asked her, as I mentioned before, there is something called as the patient dignity inventory, which asks the questions. And one of the questions that I generally ask is there anything we can do to make you feel more comfortable? Leave the rest. Just this one question will help you ahead in the dignity therapy. So what did she say when I asked her? Sorry. What do you think she said? What would she have said at that point in time? Any guesses? You can either put it on chat, unmute, pain relief, absolutely. Correct, absolutely correct. When I asked her, please get rid of my pain. Okay, so one of the question that the pain was interfering with a lot of things. Again, what I want to stress here is, remember, any therapy, whether it is counseling, dignity therapy, is feasible as far as the symptoms are under control. A patient in severe pain will not be able to sit and talk through, isn't it? So in order to control her pain, we had to give opioid infusions, we had to give antibiotics for cellulitis, we had to immobilize the limb because of the fracture, and we had to give a neurological referral for optimization of the Parkinsonian medications. So getting all these symptom distress under control took us about 2 or 3 days. What did I do during those 3 days? Of course, pain control was the easiest to achieve. We were able to achieve the pain control within almost 24 hours because with opioid infusion. So what do you think I did during that time? With the pain under control, then but still she was extremely anxious, unable to sleep, and she was irritable despite having adequate pain control. And some of the things that she kept saying in a conversation was, I wish I could go to the washroom on my own. I hate being a burden on my husband. I hate it when he has to clean me up after, or when he has to give me a bedpan in the bed. I don't like him doing that. And she was also very active in a theater reading, which used to happen in her home. She said how she missed not being home because she was not able to participate in the theater reading workshop. She kept talking about what would happen to her husband after her death, because they have been together for so many years. And she was asking, will I survive long enough for my son to come and see me, Aditya to come and see me? These are the questions that came out in the conversation that I had with her. So when we look at, when with her pain under control, much of her physical symptoms settling down, the next step was to find out who is Naina, who is this lady. I am seeing a 61 lady with Parkinsonism, with fracture femur, with pancreatic cancer. I am seeing a patient, isn't it? I'm not seeing the person within the patient, right? So once her symptoms were under control, our next part was to explore who she is. And that is what we call as personhood. And this personhood, as we see, is made up of multiple fragments, right? We have what we call our core self, or what we call as our innate self, right? What is the innate self that we have? It's our value, our religion, our culture, our belief systems, right? These are our innate self, something that we have grown up and we value a lot. Then there is the individual self. My individual self is that I am a doctor, I am a banker, I am Seema, my name is Seema, right? I am the mother of so and so, I am the wife of so and so. These are individual selves, what makes us what we are, right? Then there is the relational self. It is about how we interact with the people around us, what support we get from those around us, support that we get from our family, support that we get from our friends, support that we get from the society as a whole. That is what we call as the relational self. And then the societal self. It is about our relationship with the society. What are we giving to the society, right? As a doctor, my societal self is to heal those who are sick. As a teacher, what is it? My societal self is the something that teaches children, right? Contributing to the society. How am I going to? And then how the illness impacts every part of that individual self. These are the things that I would tried to understand about Naina. So what did I know about Naina? I knew that she was a banker. She worked in a bank. After her retirement, she pursued literature. She got her master's in literature, and she took up a job of teaching literature in a college. Okay. And sorry. And then what was her societal self? She always wanted to give back something to the society. She was very altruistic as she was creative. Okay. And she was extremely independent. Her core self, as we call it, she was a very independent woman who didn't want to depend on anybody. She liked to be very clearly told what was happening to her. She clearly told us, don't hide anything from me. I want to be in control of my life. I want to know, even if I am dying, I want to know about it. And she said she believed in living well until death. That is what did living well mean to her? Being able to be productive physically and cognitively to contribute to the society until the very end. So this was something, some indicators of her core self. The third one was she was part of a theater reading workshop. She ran a self-help group for underprivileged women. She made handmade, helped them make handmade items like jewelry, purses, paper mats, etc. She liked to listen to Frank Sinatra music. She enjoyed paintings of Van Gogh and loved to read books from Dan Brown, and Shakespeare was her favorite. And she had good family support. She got most of her strength from her husband and son. Okay, husband and son. And she had plenty of friends whom she would share her feelings with. Not everyone, but some of those friends were extremely close and very supportive of her. So what does this tell you? How is Naina's story here different from what I showed in the previous slide? How is it different? The first slide I showed, right? What was different? Anybody?
Very different. There she was undergoing more of pain and in agony.
Yes.
Now we are talking about her various aspects of life.
Yeah.
Once the pain is gone, maybe she is also ready to talk, ready to interact.
Right. So
getting to know her as a self.
Yeah, getting to know her as an individual. So now when you read the first story and when you read this story of her, how different did you feel?
Knowing from her point of view.
Pardon?
What she is, what she likes, what she dislikes.
Yes.
What is she?
Yes. So
initially it was only her illness, sickness.
Only her illness and sickness, isn't it? When you read this part of what Naina is, do you find some positivity, some hope in this slide? Do you? Anybody?
Yes. Why
Yes?
not? Yes.
You did. When you saw the previous slide with so much of difficulty, what did you see?
One thing I noticed is here in the second slide, she has a very good family support.
Yes.
So I mean the strength that she gets from her husband.
Yes.
So and then I mean she has a very good job at being a banker. So all those things are very positive.
Very positive, isn't it?
Yeah, yeah.
So as doctors, when we focus only on the disease, what happens? We lose this, isn't it? Right? Right? We lose this part of the story completely, isn't it? And when we work in a hospice, when we work with palliative care patients, we cannot give much hope in terms of medical cure, isn't it? So we have to look at the personhood to give them different aspects of hope, which I will talk about later. So what I wanted to say is the journey from patienthood to personhood is not only for the patient, but it is also for us as healthcare providers. We have to change the way in which we are looking at our patients, right? Only from seeing the disease aspect to seeing them as individuals. Okay. So keeping that in mind, now how am I going to apply dignity therapy into improving the care of this person, right? So the first thing is continuity to self. So can you tell me, in Naina's case, how can we preserve her continuity to self? What is continuity to self? I'm sure we all understand, right? It is about, we have continuous memories of our past, our present, and our future, isn't it? We are one person who are living that, and we carry that, our hopes, expectations, dreams of the past into our present, and maybe to a certain extent into the future, right? And how are you going to preserve Naina's continuity of self? This is the real patient. So I'm trying to consciously remember the changed name that I've given her because the real name of the patient comes into my mind whenever I speak. So anyway, how do you preserve continuity of self in this patient? In Naina. Anybody wants to try? Simple things, not very complicated. Yeah.
You can help her keep going with the interests that she already has, like she's a part of the theater reading workshop group, etc. I think she could, with difficulty in mobilization, I think she could still actively participate in that, which might interest her.
Yeah. Absolutely right. So one of the things what we did exactly that. We asked the theater reading group to come to her hotel room where they could do the theater reading. Okay, we put in a Zoom connection so that she could see that people making jewelry and she could help them, right? And the role preservation, right? The role of of an altruistic creative person. We allowed her to continue. Once the tremors were under control a little bit, she was able to paint in she was making these table napkins, she was painting those to gift it to her friends and to the family before she died. Okay, so she was making those things. So we had to get the pain and the tremor under control so that she could continue painting. And she gave us all doctors a small bookmark, nicely painted bookmark with some quotes written on it. Okay, she kept herself so productive, isn't it? So we preserved her role for her. We gave her pride doing these activities. She, there was a sense of pride, isn't it, that sort of maintained in doing all these activities. And maintenance of hope, as we said, right? See, when medically we could not give her much hope, right? We could not operate on the femur. We could not promise her that she would walk. We didn't know whether she would survive until the time the femur heals, right? We didn't know the prognosis was not very clear at that point in time. And even she was bedbound. Her need was to at least go to the toilet on her own. We knew that was not possible, right? So there was no hope from the medical aspect, right? That is why we needed to know her as an individual to maintain different aspects of hope in living. Okay, maybe not hope in terms of medical care, but in terms of living, we could still maintain hope. Even in the worst of circumstances, there is always hope. So it is up to us to find out where that hope is. And that is possible only if we know the individual very well. We know the person that we are treating, not just the patient, right? And the other concern was legacy concern. What is legacy concern? What am I leaving behind that my family will remember me by, or the world will remember me with? Okay. And then there were other, I'll come to the legacy concern a little in detail later. Then there were other concerns that we took care of. She needed privacy. She was a very private person and she didn't want her husband helping her to attend to her needs, like going to the toilet or body needs. That was sort of, she was feeling very devalued when her husband had to do it. But when we kept a nurse, paid nurse, right, to do it. She did not feel obligated, right, because she was paying the nurse some amount of money to take care of her. So she was much more comfortable with that. And the friends were there who would visit. Some would visit daily, whom she liked. The others, were spaced out. We looked after the social support, and the aftermath or concerns about what is going to happen later, we addressed that. We had a home death protocol put in place. Once she goes back home, whom all she will call when she's dying, like who should be there with her husband to support her husband. Okay, and she wanted to say goodbyes to the family, so we had to put that process in place, though we didn't know when she would die, but she wanted to complete the process of saying goodbyes. She wanted to donate her body for research to the hospital. Body donation she wanted to do. We had to put those protocols also in place. She wanted to discuss with her husband where he would live after she dies. So she didn't want him to live in the flat. So they had to look and arrange for for a retirement home where her husband would have adequate companies, and she wanted to create mementos for family and friends. So this is the aftermath concerns, legacy concerns we addressed. All this, once her physical symptoms were under control, we were able to talk about all these things. So what is dignity therapy? Dignity therapy is a therapy that looks at continuity of self, maintenance of pride, hope, role preservation, aftermath concerns, and legacy concerns. Okay, and the most important aspect of dignity therapy is what we call the care tenor. I'm sure I've discussed this last time with you. How we treat our patients is extremely important. So focusing on the personhood of that individual, on the person, not that we are treating, is extremely important. So these few concepts of dignity concerns are addressed in dignity therapy. So now how are we going to do it? As I mentioned, it is very important to know the person who has the disease, along with what sort of disease the person has. What happens in regular medical care is we just look at what sort of disease the person has. We don't look at the person who is having the disease. Dignity therapy is one therapy that shifts your focus into to the person. So it's a brief psychotherapeutic intervention, and it involves creation of a document. This document is called as the generativity document or the legacy document. Okay, what is written in this document is the life history of the patient, their roles and accomplishment, from what they think were their important roles and accomplishment that they have had. What do they want to say to the world, to their family, to their loved ones? And how do they want, what aspect of themselves do they want their loved ones to remember them by once they are gone? And what are the life lessons that they have learned in their life so far? And what are their hopes and dreams for their family members, for their son, for the husband? What are their hopes and dreams? And some advices that they want to give to the family, how to face the future. So all this is collected from the patient through a process of interviewing, and it is prepared in a document form, and the patient will give it to their loved ones as a, it's a reminder about when they are no longer there. It is a legacy that they have left behind for the family. So this is what dignity therapy does. So there are multiple steps in dignity therapy. So first is to find out which patient is eligible for dignity therapy. And then you have to introduce what this dignity therapy is to the patient and the family and get their consent. Okay, then you have to clarify. And if they have any doubts about anything, you clarify that. And there is a protocol of 9 questions that you will ask the patient. So you give it to the patient and the family beforehand, so that they are familiar with the questions that you are going to ask them, and they prepare the answers. And then you do what you call as a framing history. What do you do in the framing history? You collect details about the patient, the age, the family, how many people are there in the family, the names of the family members, all that you collect, the demographics you collect. Then you do the dignity session. You audio record the session that you are having with the patient. After you finish the session, you transcribe it, you edit, and you clean the transcript. I will discuss each steps in detail. Then once you have done the editing of the transcript, you give it to the patient to read and ask them if they are comfortable with the transcript that you have prepared, which is the final editing. And then you put it into a more structured form and create the document as per the patient's wish. You can decorate it with pictures, photographs of the family, in whichever way you sit with the patient and do it and hand it back to the patient. And the patient will then give it to their family members as something to preserve for times that come by. So that is the whole step in dignity therapy. So you can do this on anyone who's having a life-threatening or life-limiting illnesses. Dignity therapy has done for cancer patients, for neurological illnesses, for the elderly, geriatric age group, in patients with terminal renal disease. They've done in multiple settings. And the one thing that you need to have is a patient who's interested and is motivated to take part in it, because it involves constant cooperation from the patient also. And you should be able to communicate with them in a same language. That is extremely important. If patients are too ill, they may not be able to participate in it. If the survival is less than 2 weeks or they are imminently dying, probably that is not the time to do. Though of late, they have done studies in patients with dementia also. It is better to avoid that in patients with impaired cognitive ability who have. So when you how do you introduce dignity therapy? You tell them that it has helped people with significant medical challenges. It has helped them to cope with their disease, improve their quality of life. It gives them an opportunity to talk about some things that is very important to them. And it can be given for keepsake, as a keepsake to their loved ones, even after they are gone. So these are the things that you tell the patient when you introduce the therapy. And this is the dignity psychotherapy question protocol. As you can see here, there are 9 semi-structured questions. You can ask, you don't have to go step by step in asking the questions. Sometimes, one question flows into the other. What you do is you ask them to tell about their life history. Are there any things that you want your family to know about you particularly? What are the important roles that you have played? What are your accomplishments? What are you most proud of? And anything that you want to tell your loved ones? What are your hopes and dreams for your loved ones? What have you learned about your life that you want to give it as a gift to your family? Are there words or instructions that you would like to offer to your family to help them prepare for the future? Are there any other things that you would like to introduce? So generally it is about connecting patients back to their past life, pulling out important life events and the lessons and passing it on to those who are going to survive after them. Okay. So as I said, the framing history is you learn about the demographics, disease, and the details of the family you look at. And you can do dignity therapy in the presence or without the family. You can do it anywhere. It could be in the hospital, it could be at home, or it could be in your clinic. And basically, after introducing the dignity therapy, you can do the dignity therapy within 1 week. Okay, because you may not have enough time with the patient, isn't it? Since all of them are going to have end of life, you try to finish this as soon as possible. When you move on to the next step, the process of interview, the therapist has to be very highly engaged, active listener, and you should have a non-judgmental attitude. Okay, when a patient is going to open up their life history in front of you, having this dignity affirming attitude. You remember last time we said A, B, C, D, right? Do you remember A, B, C, D of dignity affirming stance? Your attitude, your behavior, having compassion, and having empathetic dialogues. You should be master at this before you start the therapy. Once you confirm the consent, generally the interviews are between 60 minutes to 1 hour. 60 minutes, 60 to 90 minutes, you audio record it. So the 9 questions are like these dots, right? It will give you multiple aspects of the individual's personality. Once you transcribe, you edit it and you connect the dots to make a life story of that individual. Like the story, you do it, right? And then, for example, when the therapist asks, one of the things that I find it very easy is, imagine that you and I are looking through a album, okay, of your life. Tell me in as much detail as you can some of the pictures that you might see in that album. So generally, patients will talk about some things that are very important to them in their life. One of the patients said, I remember how I met my husband. The first time I saw him, I liked him. We got married and we are married until now. So what would be your next question? I gave you an opening in that dot, right? What is your next question that you would ask? Any guesses?
How is your tuning among each other?
Okay. How are you with each other now? You've been married. How has the marriage been? Yes.
Memories that they might cherish.
Yes. When you said you first saw him, you liked him. Do you remember what you liked most? Right? What will happen at that point in time? Can you imagine? She's going to
Will be
smile.
happy.
Yes.
Yeah.
The happy memories you have brought. You have connected her to a part of herself that has been lost in the process of the disease, isn't it? Right?
Yeah.
So she smiled and she told about, what she liked about him. And she also told that after marriage, how she realized that he wasn't what she had imagined. That part of it was very different. Okay. And both of them laughed about it, right? So you had brought back a very important memory and some episodes, of joy, and that momentarily took away the person back away from this deceased state, isn't it? So it provided diversion also, as well as it provided connectivity to self, right? Right? Continuity to self. It gave her that continuity to who she was. It re-established that relational thing between her and her husband, right? Just one question had multiple benefits, right? Sometimes we have to remember there could be ugly stories. It's always not going to be smile, right? There are going to be ugly stories. Remind them when they want to talk about the ugly stories that once delivered, your words will have a lasting impact. One of the patients was very angry with her son, and she said some stories about very harsh words to her son. I had to record it, I had to transcribe it. But when we went to the editing stage, I asked her, do you really want this on the record? Right? Because this is what your son is going to remember you by later on. Right? Would you like to keep this or would you want me to remove it? She said, no. I said it in anger. Let's remove it. I don't want that to be part of my legacy to my family. Right? So we removed it. It did 2 things. It gave her the space to ventilate a feeling that she never expressed otherwise. Right? But at the same time, we ensured that those words were not put into the transcript that was handed over, right? So that it does not cause, or give them the option, if that is an unfinished business, would you like to discuss this face to face in the presence of a therapist, so that this concern is also passed on. Okay, so this is something that you need to do about ugly stories. Yes, Avantika.
Seema, to this, I have not done it in any editing form, but I've started this in Snehachal Palliative Care. I'm a psychologist over here. So I've started with my 24 years old patient, and I would like to share with everyone that he has a cancer in stomach. So he's very good in writing and expressing. So when we asked him to express his views,
You're muted, Avantika.
where he realized at a teenage he was very much away from the family, but while writing his journey, he told कि when I was diagnosed with the disease, that time I realized कि my parents and my only sister got more connected to me, the friends, the life of friend circle, and where I used to feel कि they are the special people. But when I was diagnosed, that time I realized कि no, it's only the family who stands by. And now when he's into the palliative care, he keeps on expressing his like loopholes, how he was away from the family, how he had to face different things with his family, and now how he find himself so connected with his family.
So it gives them a venue to talk about things that they wouldn't have thought about otherwise, isn't it? They wouldn't have expressed, thought about it, or even verbalized it. We are giving them an opportunity to do that. Thanks, Avantika,
Yes.
for sharing that.
Thank you, ma'am.
And then step 6 is debrief. Always remember, when we navigate this, it can be very traumatic for the patient. So give them that opportunity to debrief. How was that for you? Was it hard? Is there any anxiety or misgivings about the interview? We will give the document only if you are comfortable with it, assure them of that. Transcription and editing. Normally I do it verbatim, and then put the chunks together, the story together, and then in the third interview you give the document back and read it out to them, so that they can remove what they want and keep what they want. And in the fourth interview, the document is handed over. Generally, the document, the front page can be written in calligraphy. Some want it decorated with, they will sit and they do that stars and jewel, those pieces, they decorate it and give, or whatever, in whichever way they want it, you can do in the fourth interview. So primarily what we do is understanding the core self of the person. We try to encapsulate what is most important, most memorable, and worthy for being remembered of that individual, that core self of that individual, and we acknowledge the personhood of that individual. That's what is done in dignity therapy. Okay. And is it helpful? There are plenty of studies which indicate either ways, like, for example, this was the first one of the first studies published by Chachino, where they found that most of the patients were satisfied with the dignity therapy. There was a heightened sense of dignity, increased sense of purpose, high sense of meaning increased after doing this therapy. They had an increased will to live, and they felt that it would help the patient and the family. And they felt that this therapy showed a promise for suffering and distress that was related end of life. This was a systematic review published in 2017, I think. Sorry, published in 2016. And here also, in Chorchinov's previous study, they said there was no difference in anxiety and depression. Whereas in this systematic review, if the pre-dignity therapy, there was higher level of anxiety and distress, that after dignity therapy, the anxiety reduced, but there was not much on the depression scores, not much changes was there. But there was definitely better, patients were happy with the therapy and more satisfied. This was a meta-analysis which was done in 2020. What did it show? It showed that dignity therapy decreased the score of anxiety, depression, and dignity-related distress of the advanced cancer patients. It showed some change when dignity therapy was done. This was again published in Supportive Care Cancer in 2021, where again it showed that dignity therapy in patients with hematological neoplasms, there was good efficacy in improving the spiritual well-being and hope. These are the two things that were looked up. They said that included. So This was a RCT that was done in Lancet Oncology. It has been published, where there was no statistically significant differences in distress level, but qualitatively both the patients and the family members felt that it improved the quality of life. So evidence suggests both ways. Some have shown significant difference in the psychological and spiritual distress, some haven't. But across sections, what it has proved is that patients feel much better after the therapy. There is increased sense of satisfaction between the patient and the family members. But statistically, this has not been significant. The one difficulty has also been that different things have measured different outcomes. Some have looked at anxiety, some have looked at depression, some have looked at spiritual distress, other studies have looked at hope, some have looked at dignity related distress. In the last class, we looked at a patient dignity inventory. Do you remember that? 25 questions we had looked at. That will help you identify dignity related distress, right? We should, I think, compare with that and see whether there has been any improvement. So still a lot of studies can be done to look at the efficacy. And finally, what do you see here? What is this? You can see a picture, right? What is that?
Birds and a blue sky.
Birds and a blue sky.
Oh,
What is this?
is that a storm?
Hmm.
I don't know.
Okay. Right? It's very difficult to decipher what these pictures are, isn't it? Right? So
Yeah.
this is the psychologist, right here. Here you have the physician, right? Here you have the occupational therapist, right? And here you have the patient. Okay, so care is very fragmented in our setting, isn't it? Right? The doctor will look at only the physical symptoms. The psychologist will look at only the psychological issues, anxiety, depression, whatever. The occupational therapist will look at the limb edema, right? And the patient is coping with his own problems, right? Right? So basically what we look at patients in bits and pieces we see. So our care, we don't get the whole picture, isn't it? It's a very famous painting that I'm showing you. Any guesses? Right? This is the final painting, right? So what dignity therapy does is, rather than looking at patients in bits and parts, right? It gives you the picture of the whole person who is, and the patient, right? The person who has the disease, it gives you a picture of that. And that is what the advantage of dignity conserving care or dignity therapy is. You get to understand the whole person, and then you get to understand the bits and parts of the suffering that the individual has, and you learn to handle it in a better manner, right? So this is taken from Chachino's book, The Final Days, Final Words. So one of the patient has written, there were a lot of things that were brought back to me after the dignity therapy. The questions I thought, I wouldn't have thought of that. On a regular basis, when we ask some questions, they wouldn't have thought of that. The questions made you think. It was the most important session for me. Doing the life review was a lovely experience to do. Leaving your words of wisdom was a bit corny because people have their own wisdom, but it was an important question to ask. Dignity therapy brought out things that hadn't struck me, like the relevance of certain things. And like Avantika just said, the fact that, what he thought about the family being more important than the friends that he was looking out for support. These are things probably that they may not have vocalized or even accepted at any point in time. So the dignity therapy gives them an opportunity to bring all this out. These are some of the references, and thank you. Open to any questions.
Thank you, ma'am. Thank you very much.
Therapy seems to be very specialized thing. do you actually charge for
Sir, your voice is breaking. I think it's
or
better to switch on the
bringing
video.
out document?
Sir, please turn off your video and speak.
Hello?
Sir.
Hello?
Yes, sir. It's audible now, please.
Go on.
Yeah. But asking is generating this document looks like a very specialized thing. The charge for bringing out this document?
Yes, sir. I didn't get the first part of your question because your voice is breaking up. If you can type the questions, that would be nice. Because I can't hear you clearly, sir.
Okay.
Any other questions?
Madam,
Yeah.
Sorry.
Akriti, I think.
Yes, ma'am.
I wanted to ask how relevant is dignity therapy for those who have undergone trauma and traumatic experiences?
Regarding trauma and traumatic experiences, I haven't read much about dignity therapy being used as of now, but I think as long there are times when going back and recalling the incident can cause some amount of distress, isn't it? So until and unless you have the capacity to deal with that distress that comes in, have a distress protocol ready, sort of, then probably it might help to relieve that experience and disengage. It's sort of a desensitization also, no, in a way. So, but I have not come across any studies that have done dignity therapy in trauma-related issues.
ask you a question like being an experienced psychiatrist, what should be the ideal facial expressions of the health care providers and the people around, those who are caring and providing health care, and also people around, what should they convey through their body language and the emotions to the patient? Emotions are like contagious. So whatever emotions the caregiver has, that can go to the patient.
Yeah, so I think between the patient and the caregiver, they are sort of, the caregivers are secondary patients, basically. Like, they mirror the suffering of the patient, right? So we wouldn't advise the caregivers to suppress their emotions when they are with their loved ones, because that space is for them to share. If they cry, they need to cry together, caregivers. But when it comes to us, healthcare providers, we are at a different aspect. So when we talk about empathy, our language, communication, verbal as well as non-verbal, should be of three things: unconditional acceptance of the situation, whatever the situation the patient is in; genuine concern. You should be there to heal the patient, irrespective of what it is, what your personal beliefs or thing are. You are here to help them in the healing process. So unconditional acceptance, genuine concern, and active listening. Accompaniment, the art of accompaniment, accompanying them in their journey. You are not going to fix their problems. It's not your thing to fix the problem. You're going to empower them enough so that they can fix the problem themselves. So I think healthcare providers' attitude is these three. Whether even if it is a prisoner who has murdered somebody, when I sit with them and I'm doing dignity therapy, I should be able to accept that individual unconditionally and be genuinely concerned for the suffering that person is going through.
They'll be very sensitive and they'll be looking at your face like how long I am going to live, like what my condition is like, and everything. They'll look at your face and your facial expressions. Even not only that, especially the healthcare provider, doctors and nurses, they'll be looking at this. Not only regarding that patients who are at the end stage, even the other patients who are in the ward also. So this is a area which needs lot of training further, because they should not read anything from the facial expression of the patients and about the caregivers, that how the condition of the patient is,
Yes.
how serious the condition is, and how long he is going to live, or whether her days are numbered or not. So this all needs it's an area which you should look into, so that further training needs to be given. Actually, the wrong communications are going not only from the caregivers, but also from the family members. So many things is a communication area which needs to be addressed further.
Absolutely, sir. And so the one thing that is, it not only applies there, it applies in teaching also. Why do I say keep the video on? Right? Why do I say keep the video on? Because for me, it is very difficult to teach to blank names, you know. But when I look into your faces, when your video is on, I know whether I need to change track or to continue in the same way or not, right? Because your expressions, your non-verbal gestures feed my thinking also. So that's why I say put on the videos, because you know it makes it much more easier to teach with the videos on, with seeing the facial expression. So there is one thing called as the concept of mirror neurons, right? It's a hardwired, it's a neurological this thing, that if you see a sad film, you start crying, isn't it? Right? Because your brain recognizes the pain that is being shown. And even though you're not personally experiencing the tragedy, when you see it on screen, the areas in your brain, you know, respond to the tragedy that is seen there, and you end up crying, right? Similarly, there is this concept of mirror neuron in patient and doctor communication. So the patient looks at you, and your expression or your feelings get mirrored onto they perceive it and they respond to your expressions. So in a very agitated patient, sometimes you just hold hands and you steady your breathing, right? And you do mindful breathing, automatically patients also will calm down in front of you. They start breathing at your pace, right? And they start calming down. So at the
Where
same
we can give comfort to the patient.
Comfort to the patient. At the same time, if the patient is having bleeding and your body language is of agitation, and you start breathing fast, and you know start becoming panicky, what happens? The panic gets transmitted on to the patient also. What we call as emotional contagion. That happens, you know. So it's important as care providers for us to be able to regulate our breathing. So self-awareness and self-modulation is also extremely important when you deal with the patients. It's not only, it's first we learn it on ourselves before we, you know, move it.
And Seema ma'am, I feel like we have a proper counseling room for the patients. So from my experience, I've learned one thing: when I'm into a bedside counseling, I experience lots of disconnection, because obviously voice from the other cubicles coming. But when we are into a counseling room, then one to one it be with among the family, that connectivity goes very soon. It's like I completely agree to you the way you said you need to be neutral, you need to be completely relaxed, and then you speak to them, so that then the connectivity is really very soon. And hand holding and just sitting next to them, being a good listener, like good listener in sense whatever they want to vent out, and when they're saying it, you just listen full patience, looking at them, having an eye contact, that give them lots of relief, what I have experienced here.
So there is a question, I think Saju Thomas doctor has put in a question: do you charge for bringing out such a document? Actually, I have always worked in institutions, and right now I'm working in a hospice where our services are entirely free for the patients. So we don't charge anything, both in the hospital as well as in the hospice setting. When we are doing, we don't charge anything. And there is a lot of art of accompaniment. Yeah, spiritual training courses, though they are not available in India, there are courses available abroad. If people are interested, you could opt out to get trained in those, and hopefully we will be able to get those courses down in India. We are trying very hard so that people get access to these recognized courses in India also. Yeah.
Yeah, there's a lot of scope for collaboration and working together, like a lot of areas which you touched upon. And actually, these are areas which we have to further give training to people, and even relatives needs a lot of training. Thank you, madam. Thank you again.
Thank you, ma'am. Thank you so
Thank
much
you,
for
ma'am.
your time. And I think it was a fruitful session. Thank you everyone for being here with us. And I have shared the feedback link with all of you in your WhatsApp group and in your chat. Please go through it and fill it up. And I know some of you have doubts regarding your assignment submission. I just reopened the links to do assignment 1, 2, and 3. Those links are for those who haven't cleared, or those who haven't scored less than 70% marks. So those who have cleared the assignments, there is no need to go through it again.